Good.
Okay.
Siri here. Let me know if I can help.
Who's Siri come from?
Okay. We're gonna get started, Pam.
Is the recording?
Yes.
All right. Good afternoon.
Good
Happy
afternoon.
that everyone is here today. The reason why we're here today is to equip and empower. We're going to equip you with information that can empower you to make an informed decision concerning the coronavirus and the vaccine. As we know, African Americans are disproportionately affected by the coronavirus. It has really been a canary in the cave that shone a light on health disparities in other areas. Our population has been hesitant to get the vaccine. So we want to give education so that you can make an informed decision. And today I'm having my friend and colleague, Dr. Virginia, we call her D, Banks. She is an infectious disease specialist. She graduated from Case Western Reserve University. She is on the front lines every day as an infectious disease specialist. She is an expert in her field, and we're so happy to have Dee here with us today. I'm going to give, the other thing I wanted to say about Dee is she is a runner. She has participated in many marathons, and as we know, running exercise is very important for our health. So I'm going to give a short prayer and then we're going to begin. Father, thank you for this gathering today, Father. I want to thank you for the wisdom and the knowledge you have imparted to each and every one of us, Father. And this day we ask for people to open their minds and hearts and receive the information and wisdom and use it according to your will, Father. In the name of Jesus, I pray, amen. So we're introducing right now, Dr. D. Banks.
Okay, let's see. I want to share my screen. I think I have to be made co-host or host.
Yes, we made you co-host. Go ahead, stop. Keep them in. You should be made co-host already.
It says co-host, host disabled participant screen sharing.
Okay, let's see. Let me get my person to help because before he was able.
Oh, wait a minute.
I took care of it. I did it.
Okay,
Pastor
thank
Hood,
you.
I did it.
Thanks, Pastor Hood.
Okay. Let's see. I don't see the one on here that I want. I just did this morning.
It's green.
That's not the right one that I want. Let's see.
Cancel the share screen and then open the document and then go back and you'll see it.
So do what now?
You're looking for it on share content or share the
Yeah,
screen?
it's a PowerPoint presentation.
Yeah, just cancel that.
Okay.
The share screen, then go to your computer and open the document, then come back to Zoom and hit
All
share
right.
screen again.
Okay.
Then you'll see it.
All right, so let's see. Can I get out of here and do it? Or can I minimize you guys?
Yes.
Let's see. Okay. Now.
I think Pastor Hood is helping her.
Pastor Hood is able to do it.
PowerPoint.
I think so.
Yeah, just open your PowerPoint and leave it open.
Now I have it
then
open.
come back to Zoom.
All
Yeah.
right, so now,
Come-
let's see. Come back to Zoom.
And hit that green share content.
Oh, okay, wait a minute, let's see. Come back to Zoom and then hit share screen.
Disadvantage at our age.
Yes!
Amen.
There you go.
I feel like I'm in the 21st century. Yes,
No problem. No problem.
thank you. Okay, are we ready? Okay, good afternoon, everybody. Thank you, Pam, very much for, can everybody hear me?
Yes. we
Okay,
can
good.
hear you.
Okay, good. Good afternoon, everybody. Pam, thank you so much for inviting me to come and speak today. This is, I guess, has become my passion only because, let me preface this by saying we're tired. And so other than this is a healthcare disparity, you know, that I've always been involved with healthcare disparities, whether it's HIV, AIDS, hepatitis C, or whatever, but this is a healthcare disparity, but it's really sort of twofold because it's beneficial for me and it's beneficial for everybody else because we have got to get this pandemic under control. So let me just preface this by saying, you guys, I'm still on call today. I got to go back to the hospital. I've already seen 25 patients and I've got 25 more to see. And the COVIDs are coming in fast and furious. So it has plateaued and the numbers are starting to go up. So I just wanted to preface that by saying this. So here's who I am, Dee Banks. I work for Northeast Ohio Infectious Disease Associates in Youngstown, Ohio. I've been here since July of 2018. Prior to that, I had many, many jobs, as Pam knows, but for 15 years, I worked at UPMC, University of Pittsburgh Medical Center, the Horizon campus in Hermitage, Pennsylvania. So let's just talk a little bit about the demographics. Where are we today? And these numbers, I didn't even bother to change the screen because they change daily, hourly, but just basically globally, we're about at 120 million cases, over 2 million deaths in the United States, over 29 million cases and over 540,000 deaths so far. And this is from, in the United States, that first patient, I believe, that we had in either the end of January, beginning of February that died. And this is where we are about 12 or 13 or 14 months later. Yes, we are disproportionately affected. This slide just shows something interesting about this slide that I want to point out. So initially, we were just, when I started taking care of the COVID patients about March of 2020, I think that's when the patients started to come into my hospital. We really were not looking at ethnicity or race or gender or anything. I mean, all we were doing was trying to keep people alive. They were coming in the hospital with these new symptoms. Their oxygen levels weren't even compatible with life back in the day, but yeah, they were sitting up in the chair talking, and then we take their oxygen levels and they were down to like 40 or 50. We'd have to intubate them, put them in the intensive care unit. Many of them died. Some of them lived. Some of them lived in spite of us because we didn't know what we were doing. We were using drugs that we had heard of. We were, you know, looking at journals from China and Italy and all these places to try to get some idea about how to treat people. So then I guess about April, I was giving a talk to the Black journalists in Cleveland on a Zoom presentation. And after I gave my presentation about COVID and all of that, it was just a talk on COVID, nothing about disproportionality. Somebody in the group said, Dr. Banks, have you heard that there's a disproportionate number of African Americans that have this disease? And I was floored. I was like, no. And it was that afternoon that the journalist sent me an article from Milwaukee, Wisconsin, that was pointing out how many Black and brown people were coming in the hospital with COVID. And then after that, it just kind of snowballed. The next day, Chicago. And then I called on Monday down to the state of Ohio, you know, to ask them if they had any information on race and ethnicity. They had zero. And I'll never forget, it was that Monday that Amy Acton and Governor DeWine got up, and then they started to mention that they were going to start looking at race with respect to who was getting affected. But if you look at this slide, with hospitalizations, Black and African Americans 3.7 times more likely. Hispanics 4.1. But here's the group that's popped up that's been of great surprise to us, the American Indian and Alaskan Native populations. 1.8 times of the cases, 2.6 times of the death, 4.0 times of the hospitalizations. That wasn't the information that we had when we started, because they were not collecting the data. So you don't know. A lot of these individuals lived in remote areas. They didn't have individuals that were finding out who was dying. We didn't know that a lot of the elderly people in the American Indian population were dying because they're multi-generational households and so forth. So the demographics really have kind of changed too within the last year, but we are still way up there. This is another slide. If you just look at race and ethnicity, I believe this is cases, race and ethnicity. If you look at 65 years and older, non-Hispanic, American Indian, Alaska Natives, 1,308, non-Hispanic Blacks, 1,588, Hispanics, 1,497, and then let's get down to non-Hispanic Asians or Pacific Islanders and non-Hispanic whites. So huge difference in who's being affected. So we've lost at least, and this number changes too, but you understand what I'm trying to say here, that we've lost at least over 50,000 Black lives to COVID to date. And Black people account for 17% of COVID deaths where race is known. So some of the factors that I did a Zoom presentation with somebody this morning, and there's a slide that she mentioned that I wanted to just read. So let me just break down some cities. And this is up-to-date information. Washington, D.C. represents 45, Black people Black and brown people represent 45% of the population. They represent 75% of the deaths. New York, hold on a second, I'm sorry. Nobody's supposed to be coming to my house, sorry about that. New York, 9% of the population, but 19% of the deaths. Louisiana, 33%, 65% of the deaths. Wisconsin, 7% of the population, 39% of the deaths. Ohio, this isn't completed yet, 14.3% of the population, but 14% of the deaths. And that is felt to not be completed data. I am so sorry. Somebody's knocking on my door. I'm sorry. I'm so sorry. I don't know what that was for. It was a thank you edible basket. So I guess I'm happy I got that. So anyway, you understand where we are in terms of those individuals that are affected. So what are some of the factors that increase community spread and individual risk where it comes to Black and brown people? Well, we've been talking a lot recently about social determinants of health. So you look at neighborhood and physical environment. This may limit their housing options to neighborhoods with mostly other racial and ethnic minority groups, lack of adequate transportation, crowded conditions, lack of adequate foods. We know about the food deserts that we hear a lot about, and then multi-generational households for many cultures. Like I said just a few minutes ago, where we're losing a lot of the elderly American Indian populations that live in multi-generational households because of COVID. So let's talk about health and healthcare, lack of access to quality healthcare, health insurance, and/or linguistically and culturally responsive healthcare. Inequities in treatment results in distrust of government and healthcare systems. These barriers increase risks for poor health, and health outcomes by limiting health promotion, disease, and injury prevention and condition management activities. So again, with respect to social determinants of health, occupation and job conditions contributed. We disproportionately are represented in essential work settings, healthcare facilities, farms, factories, food production and processing. And these occupations did not lend themselves to us being able to stay at home. Like a lot of people said, well, you know, I'm working from home on my computer. I can, you know, I'm working downstairs and somebody else is working upstairs. Well, a lot of us don't have a house enough that's huge where we can be quarantined from each other. And many of us don't have jobs where we can work from home. I had to work every day, and a lot of other people did. You remember those stories of the bus drivers and taxi cab drivers that were dying early on in New York when the pandemic was really bad there because they were essential workers. Grocery stores and public transportations, we have to work there. More chances to be exposed to COVID-19 because these types of jobs require frequent or close contact with the public or other workers, and they involve activities, again, that cannot be done from home. So again, all of these things, disparities, risk of exposure to COVID-19 because of the slides that I mentioned, risk of severe illness from COVID-19 because of all the comorbid illnesses that we have, disparities in COVID-19 illness, disparities in COVID-19 hospitalizations, and again in deaths. Income and wealth is important. People from some racial or ethnic groups have lower incomes, experience barriers to wealth accumulation, and carry greater debt. Such challenges may make expenses, paying medical bills, and assessing affordable quality housing, nutritious food, and reliable child care difficult. I don't know, as I have said to people, I don't know, because I have 4 children. I don't know what I would have done during this pandemic. I completely relied on childcare when my kids were growing up. I didn't have any family around either when I was training in Cleveland or in Youngstown. And so it would have been difficult for me to go to work to try to find someone to take care of my children. We don't think about political determinants of health. And you might say, well, what does that have to do with anything? So my friend Daniel Dawes, who happens to be director of the Satcher Health Leadership Institute at Morehouse School of Medicine, has written a book called Political Determinants of Health. He wrote a book about 3 years ago called Obamacare. A really interesting book if you have not read it. But this book about political determinants of health essentially says, amongst the many other things in the book, who you vote for depends a lot, many times, on what your healthcare is going to be like. For example, there are about 10 states, most of them in the South, that are represented by governors of certain groups. This is not a partisan conversation that we're having here, but they don't have Medicaid expansion. And so what does that mean? They're, you know, without Medicaid expansion, a lot of these people are not going to be able to, or aren't able to get the kind of care that they are needed. Monies are not allocated to a lot of the healthcare centers in urban centers for urban populations. I don't know if you saw yesterday, thank God for Biden and Harris, but this is not a political talk. The CDC is yesterday putting out $2.5 billion, I believe I saw yesterday, the Center for Disease Control, for healthcare disparities, programs, and so forth with respect to COVID-19. So if you all, anybody in Cleveland want to get together and write some grants and so forth, because it ain't over. This pandemic ain't over. Get together and write some grants and get some of this money. Now is the time to do it. If you all want my girlfriend who works with the CDC, Friday, I knew there was going to be some kind of announcement. So I was on the phone calling her at the CDC. Do you have it yet? Do you have it yet? She's like, no, I can't send it to you until Biden leaves. I'm like, okay. So she finally sent it to me, and it's $2.5 billion. Y'all need to get some of that money. What can we do to move towards health equity? Well, just like today, important conversations about how structural racism affects healthcare. The strongest predictor of health is socioeconomic status. While financial instability is considered the fundamental cause of health disparities, this association between socioeconomic status and health is often dependent upon race. So what can be done for physicians advocating for all aspects of patients' health, including food, housing, and universal broadband internet? You know, a lot of these kids are going to be behind when the smoke settles and the dust clears about all of this homeschooling and hybrids and so forth, because not everybody in their household has access to internet or computers or the ability to do all this homeschooling. I was watching Ellen about a month ago. I don't watch Ellen a lot. I don't watch much television, but I just happened to turn it on. And she was giving this woman who happened to be African-American, I think she had about 4 kids, and she was putting all her kids all in the car and driving every day to a hot spot in Chicago so that her kids would be able to do their homework. And I thought, what a brilliant idea to put hotspots all over cities so that parents who might not have access to Wi-Fi or whatever can bring their kids so they can stay up with their, studies. Again, involving policymakers and physicians, expand access to mental health care and treatment of substance use disorders that, are going to, I'm sure, be a lot more once this is halfway over. End the stigma that impeded the prevention and care of HIV, AIDS, viral hepatitis, STDs, and other infectious diseases. We can call on policymakers to expand Medicaid and extend the moratorium on evictions during the pandemic. Standing up for science, advocating for increased funding for public health and infectious disease programs, including safety net programs like Ryan White or whatever you call it in your area, and federally funded qualified health care centers. So let's talk about the vaccine. And this is an important conversation that we need to have because, however many of us are on this conversation, I want one to take it to 10, and hopefully those 10 will take it to another 10. We got to get people vaccinated. So first of all, we have 3 vaccines today, 2 messenger RNA vaccines and 1 non-messenger RNA vaccine. The platform that it is introduced into the cell to make antibodies is by way of an adenovirus, and I'll talk about that in a minute. So this, the proteins on the outside of the cell of the virus are called spike proteins, and those are those little red things that look like spikes. And so these proteins are called spike proteins, and they allow the virus to attach to the cell and replicate. So the virus is injected into the person. It contains the messenger RNA that goes into the cell and makes these spike proteins. Your immune system does not recognize these programs and then attacks them by producing antibodies. So the body is fooled. Now, you got these spike proteins where the virus is attached to and they're into the cell, and the body sees this as coronavirus. So when the actual coronavirus then presents itself to the person or the body, the immune system says, aha, I see some coronavirus coming in here. That's the real coronavirus. And now they've already got antibodies in your body already against it, and that's how the vaccine works. So those are the messenger RNAs. Again, a schematic diagram, injection into the deltoid. The vaccine triggers the production of the spike protein, and then antibodies are developed specifically against it. And now when the real COVID comes in, it says, aha, you're not getting in here. I don't know if you've seen this young lady. Her name is Kizzmekia Corbett. She happens to be another North Carolinian. She is works with the NIH, and Fauci started talking about her in last May as this young woman, and she was featured in the New York Times. And she has been working on, and was responsible for helping to develop the Mrna vaccine. And I happened to be on a town hall presentation with her about a month and a half, well, maybe about 6 weeks ago. No, about 6 weeks ago now. And I was on with several other physicians, and we said, wow, we've never heard anybody explain vaccine development like she did. She just broke it all down for everybody. Well, she's now on the speaking circuit, and it's virtually impossible to get in touch with her, but This is Kizzmekia Corbett. And I wrote her a little email after we had our town hall and told her that I really seriously expected that she would be nominated for a Nobel Prize one day. So remember the name Kizzmekia Corbett. They call her Kizzy. So let's talk about the vaccine trials. We have Pfizer and Moderna. And as you know, they were given EUA, emergency use authorization. So they're not official, it was not official, it was an emergency. The FDA gave the emergency use of these vaccines. So let's talk about Pfizer. There were 43,000 people enrolled, 150 clinical sites in 39 states. This is just in the United States. Racial and ethnic distribution, 10% African-American, 13% Hispanic, and then you see the rest of the breakdown there. 45% ages 56 to 85, 30,000 enrolled, 80, that's Moderna, 30,000 enrolled, 89 clinical sites, 20% Hispanic, 10% African-American, Black, 4% Asians, 64% ages 45 and older, 39% 45 to 65, and 25% over 65. Just general information on Moderna. It's a 2-dose series separated by 28 days. I got the Moderna. It's indicated for 18 years of age and older. Pfizer, 2 doses, 21 days apart. Another intramuscular injection. This is for 16 years of age and older. Both these vaccines require ultra cold storage, but you know, whenever I give talks, I say, like today, this is as of March the 20th, 2021 at 4:30, because the data changes by the second. So you might say, well, Dr. Banks, I just read that they don't need that. So I stand to be corrected at every second. So I did just read though that they feel that especially the Moderna might not need as cold temperatures as they once thought. So here are the authorized groups, as I mentioned. So how do we know the vaccine is safe? These are from the clinical trials, and the majority of side effects compared to placebo were fever, fatigue, headache, some chills, some diarrhea, and new or worsened muscle pain. I pretty much had the fatigue and the muscle pain. I think that's been pretty consistent with a lot of my friends and colleagues. Several people, though, developed fevers and chills. Again, here's broken down: 59% with fatigue, 51% headaches, 37% muscle pain, joint pain, and chills, and so forth. Bell's palsy was in 4, and right now we don't have any causal relationship with why that happened. Anaphylactic reactions in 8. We're now up to, I forget how many doses we have distributed now, but we're in the multi-millions of doses of this vaccine distributed. And I think by now, if we had had some, I was trying to see if this slide today had it. Well, at least in Ohio, there have been 3,972,000 doses of vaccines delivered. The first dose has been given to about 20% of the population, 2,390,000, and the second dose, 1,021,000. Moderna, pretty much the same, 3 Bell's palsy patients in there. But as I tell people, I served on the FDA from like 1996 to 98. And it's one thing taking a drug or a vaccine from clinical trials where you have only 30,000 people. But when you take it into 1 million people, quite naturally, people are going to have more things going on. This is what happened with the AstraZeneca. Now that it's been in 17 million people, they started seeing patches of people with blood clots. But what they figured out and found was this is just the natural order of things, at least as of March the 20th, because they've gone back to using as of March the 20th at 4:30. This was just in normal population. And this is what they are feeling with the Bell's palsy issue too, that after so many millions and millions of people, there's a certain group of people anyway that are going to develop Bell's palsy that has nothing to do with the vaccine. Now, people have memories, those of us that are in my age group, of when the flu, there was a swine flu epidemic back in the mid-'80s, and they were giving people vaccines, and some people did develop Guillain-Barré, which there was a causal relationship with the vaccine, and they took that off. So again, you know, this is why I say the symptoms that you're having, the injection site swelling, fever, chills, tiredness, and headache versus the other slide, it ain't COVID. So I just tell people, try to deal with it. It is not COVID. So how do we know it's effective? This is an important slide. So basically, Pfizer and Moderna were 95 to 94% efficacious. And basically what they did, as we know, they prevented hospitalizations and deaths. What we do not know still is whether, and this goes for Johnson & Johnson, is whether or not after we're fully immunized, that's 2 weeks after the second dose, whether we can still get the virus and become colonized with it, meaning that it's just in our mouth and it's not causing any trouble, but we could possibly transmit it to somebody else. This is why it's important to continue to wear your mask and tell people, well, why do I have to wear my mask? You know, I got my shot. This is why, because we don't know if you're immunized and you have coronavirus and you come in contact with somebody who's cancer chemotherapy patient or immunocompromised, you could still pass it on potentially. So this is how the 94, 95, and 94% data came up. In the Pfizer, 170 confirmed, 106 were observed in the placebo group and 8 in the vaccine group, and 196 confirmed cases of COVID. In the Moderna group, 185 symptomatic cases in placebo and 11 in vaccine group. That was pretty significant. Again, you know, pretty safe. Well, now we, in so many millions of people, we feel that it is a relatively safe and efficacious vaccine. Johnson & Johnson, the new kid on the block, one and done, recommended for people ages 18 and older. Clinical trials, now they had a more diverse group, 58% white, 45% Hispanic, 19% Black and African American, 9.5 American Indian, and so forth. I want to address the issue of, well, you know, they said it's only 70% efficacious. Let me explain this. You cannot compare the J&J 70% to the Moderna and Pfizer. It is not a head-to-head, apples-to-apples comparison. The 70% represents the fact that Johnson & Johnson clinical trials were done during the height of the pandemic. It was also done in multiple countries where there are variants. And so it wasn't effective in 95% of the people. It was effective in 70% of the people. The good news is that we think it might be more efficacious against some of the variants. All you need to get emergency use authorization through the FDA is about 60 to 65%. We were spoiled hearing about the 95%. The only vaccine that we take, or some, not me because I have immunity, is measles. Measles is around, I don't know, 88%. Even the flu shot's only 65% effective, and we take that every year, once a year. So that's the difference between the 70% and the 95. As they say, don't get it twisted. They're all three just as efficacious, and they all three have that question. Once you're fully immunized, you could still possibly get it and pass it on to somebody. That's why you have to continue to wear your mask. 59% males, 45% females. But again, let me re-emphasize, no deaths, no hospitalizations. No deaths, no hospitalizations. 33.5, 60 years and older.
Vaccine.
66%, 18 to 59, 33.5, 60 years and older. Safety, efficacy, pain, redness, and swelling in the arm where you got your shot. Again, tiredness, headache, muscle pain, chills, fever, nausea, and so forth. When I was doing the Zoom presentation this morning, one of the nurse practitioners, again, information is coming out rapidly. So one lady said to me, you know, when I went in to get my shot, they told me I could only have it in one arm. and I couldn't have it in the other arm. And Dr. Banks, do you know why? And I said, well, I really hadn't heard that because I'm not really in the actual day-to-day of giving the vaccine. And the nurse practitioner said, new data is because they're finding that some women are developing lymphadenopathy, enlarged lymph nodes. And it's being confused with whether or not they might have lymphadenopathy associated with breast cancer, to the extent that she told us that they're recommending maybe waiting to get your mammogram 2 weeks after you get your vaccination because they're finding this lymphadenopathy situation. So allergies and COVID-19, these are just the, if anybody wants me to send this slide, but you have to have a significant severe allergy for us not to recommend the vaccine. Only true contraindication to the vaccine is a history of an anaphylactic reaction following a previous dose of COVID-19 or one of its components, and you can find that under FDA.gov. If you have a history of those things that are mentioned here, meds, peanuts, bees, you still need to proceed with caution. They should be carrying EpiPens, but also talk to your doctor. Blacks are trailing behind. Now, these numbers are getting better to where it's maybe not so much now mistrust and distrust as access. So we're getting the jabs or the shots in the arms, but we're still not where we need to be in terms of BIPOC, Black and brown people getting vaccinated. So everybody here not remembers, but you know, I have heard about, although I shouldn't say everybody. So when I talk about this to the millennials, I mentioned the Muppet Man to some millennials the other day, and they didn't know who I was talking about. So I said, Dad, I'm really old. They don't even know who the Muppet Man is. So for those of you that don't know, the syphilis experiment was from 1932 to 72. They looked at 600 Black men to record what happened to them when they got syphilis, and when penicillin came out in 1945, even though they knew it was effective, they didn't give it to them. And Black doctors were complicit in that. So, you know, people remember that. But I was talking to some physicians today in the lounge, and they happen to be white physicians. And I said, you know, I can't say that this will never happen again. And he was like, yeah, you can't really say never. But the regulatory things that we have today make this kind of thing extremely less likely, because this was the information was broke, the news was broke open by a journalist, and now, you know, we got CNN, MSNBC, and everybody all over everything every day, so it's hard to have something like this. Other things in terms of mistrust, if you haven't read The Immortal Life of Henrietta Lacks, you should, about a woman whose cervical cells were harvested from Johns Hopkins in the 50s, and pharmaceutical companies had made billions of dollars off of this. And the story of J. Marion Sims, who was the father of gynecology, whose statue was in New York until recently. He was doing surgeries on Black slave women without anesthesia. And then once he perfected the surgery, did it on white women. Debunking some of the myths. There's no live virus associated with this. Now, the Johnson & Johnson vaccine is the platform. Instead of a messenger RNA, it's taken in by an adenovirus, which is a common cold virus. It's genetically modified, so it's not like you're getting a live virus vaccine, but this is just the mechanism of action. And so instead of messenger RNA getting it in, it's carried in by adenovirus. Again, the side effects of the vaccine I mentioned before. DNA is encoded in the nucleus, or very center of the cell. The messenger RNA only gets into the cytoplasm, meaning outside the nucleus, so it cannot alter your DNA. That's another big question. I was asked by a certain population of young ladies at my hospital, Dr. Banks, well, I heard this, you could get sterile. And I was trying to figure out, where did this come from? Well, I looked it up. So there's false internet claim that the vaccine spike protein cross-reacts with another protein called syncytin-1 that's important to placental formation. So the COVID vaccines do not contain syncytin-1 protein or messenger RNA encoding syncytin-1. These vaccine spike proteins and syncytin-1 are very different from each other, and there's no evidence that the vaccine response creates cross-reacting antibodies to syncytin-1. As of March the 20th at, where are we, 4:43, Long-term effects, we've got the long-term haulers, and I mean, everything's popping up now. Chronic fatigue, shortness of breath, cough, joint pain, chest pain. And we don't really know right now. We're looking for some data to find out what is possibly related to the vaccine and what is not. Right now, anytime anybody has anything, they're reporting it to the CDC and to the FDA. So heart damage, seizures, strokes, Guillain-Barré, muscle pains. So we have to figure all this out as to what is really caused by the vaccine, as opposed to, I mean, not the vaccine, what is really caused by COVID. I'm sorry, what is really caused by COVID, or what is not caused by COVID. So brain fog seems to be a common theme, and fatigue seems to be a common thing. But the rest of these, we need some robust studies, and we're going to have something with 1 million people, you know, how 29 million people having COVID. We'll have some information soon. I gave a talk yesterday in Youngstown on COVID-19 and heart disease. This is just a snippet. Are the vaccines safe for people with a history of heart disease, heart attack, or cardiovascular risk factors? Not only are they safe for people with a history of heart disease, they are essential. People with heart disease are at increased risk for severe complications from COVID. This is something that you can pull up on your smartphone when you get vaccinated. You can type in information and send it to the CDC, so they'll have real-time information about how you're doing after you get your first vaccine, and they'll give you a reminder about your second vaccine. Herd immunity is when everybody gets vaccinated and we're protected and the virus doesn't have any place to host, to bounce onto. We really don't know what that number is. We think it's somewhere between 70 and 80%. There are two ways to get herd immunity: the natural infection way. So let's just have, you know, early on there was like, let's just have COVID parties, like chickenpox parties, and just let everybody get infected. Well, chickenpox is not like COVID. And in order for that to happen, you will have to accept millions more deaths, as I say to people when they bring that up, including your own, or to immunize a bunch of people, which is what we're trying to do now. So this is just a little cartoon. The blue people are not immunized, but still healthy. And then contagious disease spreads through the population. And now these people are not immunized and they're sick and contagious. And then when they're vaccinated, so the yellow people are immunized and healthy. And then when the disease comes, it's contained and the population is immunized. All those people many of those people that are not immunized but still healthy, or not immunized and sick and contagious, are protected because they are surrounded by a bunch of people who are. You hear a lot about mutations and variants. We don't know what we don't know. We're now 35th in the world in gene sequencing. There are countries in Africa that are ahead of us in gene sequencing. We're dancing as fast as we can. We could have been doing this sooner. To find out where the variants are. Our fear is that the plateauing and the going up that we're seeing now may be related to some of these variants. Nobody's saying anything now. I don't have the inside track to that, but we're looking. We think that some of the vaccines that at least the 3 that we have, are effective against the UK B117, but the others, maybe not so much. So we're, that's being addressed, and they're already working on a booster for Moderna and Pfizer. This is the end of my presentation. Wear your mask. As I told you today, I was saying, I haven't told you, but I told the group this morning, I have a lady in the hospital on a ventilator, prone, the whole bit. She got her vaccine on March the 11th. And she's now intubated in the intensive care unit with COVID. Why? Because we know that you are not fully immunized with the one vaccine. So you can still get it. This is a prime example that I said I'm going to tell everybody about. So wear your mask. You're not out of the woods. You're considered fully immunized 2 weeks after your second shot with the Moderna and Pfizer, and 2 weeks after Johnson & Johnson. But again, until we get more of a handle on being colonized with coronavirus, still wear your mask, still social distance, and I still wouldn't go to any big giant gatherings. I don't care what people tell you. Thank you.
Oh, thank you so much for that very excellent presentation and important information. We're going to take questions now. There is a question in the chat, and the question is, a lot of people have the same reservation that I have, the fast development of the vaccine and the short period of time we had to observe the effects. Are we the test subjects?
So let me answer the first part of that question. We think it's fast development, but they've been working on messenger RNA vaccines, that technique, since the mid-90s. The problem was they couldn't get it stable enough, just like we see now. I mean, it requires ultra cold temperatures in order to keep this vaccine stable where they could give it. So Kizzmekia Corbett and her group, she hasn't been working on it since the mid-90s, but the technique is not new. So we knew eventually there was going to be a messenger RNA. It just so happened that it happened now. Are we being experimented on? As I said to a colleague who happened to be white just today, we were walking out of the lounge. I was getting ready to go back to my rounds. I said, well, you know what? If we're going to be messed up, we're all in it together, because we've all gotten vaccinated, black and white. So if we're all test cases, then we all are. But I think I'm going to take my chances, because I don't want to run what I'm saying. If you walk in my moccasins every day, I think if you don't get vaccinated, you really are playing Russian roulette. And I really, honestly, when I got two COVID consults yesterday, I went up on the COVID floor and I said, I thought we were closing. And they were like, Dr. Banks, no. So I'm just, we're just weary. And the only way we're going to do this is to get people vaccinated. Now, again, it was emergency use authorization. Are we going to find in 3 or 4 years that something is wrong? I don't know. But what I do know is that if we don't, this virus, and the UK variant, is 4 to 5 times more transmissible and more deadly than what we're dealing with now. I think I'm going to take my chances.
Okay. We have another question. What about the nanoparticles in the COVID-19? What are nanoparticles, and are they dangerous? Referring to the lipid coat, the nanolipid coat.
I don't know a lot about that, so I really can't comment. I mean, I know some. I have not heard that the nanoparticles are presenting or have presented any issues or problems, but I'm just not an expert on that lipid coat.
Okay. If anyone has any other questions, you could put it in a chat.
Moderna just came out. They're looking at children. Do I think that's a good idea? Yes. Because like they found out with influenza, they used to think that it was Granny who was the vector giving influenza to everybody in the household. But then they found out that it was the little kids coming from nursery school that was giving it to Granny. So they changed the guidelines and started recommending the vaccine to get down to 6 months, because it was not always like that. And so Moderna now is looking at from 6 months up to, what is their limit? 16, I think.
Yeah. Okay, let me ask this question. There are 3 vaccines out now. Can I or should I wait and choose the vaccine I want?
Categorically, no. You should take whatever comes down the pipe, quick, fast, and in a hurry. Somebody asked me today, it was a forced choice question. Now I've already been vaccinated. What would I take? I mean, that's forced choice. I mean, like if I had 3 bags of vaccines, what would I take? Well, I mean, I'm so busy, I wouldn't want to have to remember to take a second vaccine. And it has nothing whatsoever to do with efficacy or anything. It's just one and done. But in terms of efficacy or anything like that, no, we should get whatever you are presented with, take it.
Okay, thank you. What is the death rate for people who have gotten the vaccine? How many people have died from this vaccine?
Well, there were 2 or 3 people that had anaphylactic reactions. I don't know what the actual number is. and you know, I'm sort of afraid to say, but I think with the Pfizer, there were one or two that had an antidote, but I don't think any of the I think one or two people have died from either one or two of the vaccines. I mean, out of the however many million we have, 17 million or whatever that have been vaccinated, maybe one, maybe two that's been documented and that the effect has been from the vaccine. Now, we know that there are a lot of rumors that have gone around, like Hank Aaron died after his. There was another famous African-American that just died last week, and his wife wanted to tell everybody he did not die from the COVID vaccine. So we have not proved that really, that I know of for anybody, causal relationship.
Okay, because someone reported that Newsweek said there was 937 deaths, so we really don't have a causal relationship.
We don't have a causal relationship. That information, trust and believe, will be coming out.
Okay. Another question, how effective is vitamin C and D in treating the COVID-19?
So there was a study that came out, and I can't remember in what journal it was, because we gave vitamin D and zinc and vitamin C to everybody. The jury is still out on that. At least the last information that I heard was everybody was looking really hard at vitamin D, and there might be some small evidence to show, and I don't know the causal, the mechanism of action, maybe with vitamin D, but I think it was either New England Journal or Annals, but it didn't really pan out because we were giving it to everybody. It didn't really show that we could show any definite benefit of those. But we still prescribed them to everybody in the hospital. I can tell you that we did give them, and sometimes we still do.
Thank you. Another question is, how long do you have natural immunity after you have had COVID-19?
We don't know. That's a good question. So the information that we're using is that we believe that your antibody levels, and of course this is different for everybody, you know, those people that are immunosuppressed, they just don't have the studies out yet, but we believe that your antibody levels will last upwards of 90 days post your infection, and that they probably start to wane after that. Because we're often asked, well, how long should you wait after you have COVID to get vaccinated? And we're telling most people between 60 and 90 days. Now, the CDC doesn't really say, don't take it, you know, it's absolutely contraindicated. It's just that what we have learned really kind of anecdotally, that those people that take the vaccine after they've had COVID, you know, those are the ones with the chills and fevers and all the side effects and stuff. Well, quite naturally, because they, you know, their antibody levels are at the height. But we don't know, again, we don't know, but we think at least around 90 days after you've been infected. The vaccines, again, we don't know. They're already working on boosters for Moderna and for Pfizer, not just because of the antibody situation, but also to maybe make it a multivalent vaccine to cover some of the variants.
So if you have COVID-19 already, you should get vaccinated.
You can, yes, you can get vaccinated. We just suggest that you wait 60 to 90 days because of the, you know, because of the side effect response that you're likely to get.
Okay.
So
another person asked, can they choose which vaccine they want?
No, most centers don't allow you to choose. I mean, if you can, I suppose you can, but I'm not aware of the centers from anecdotally from around here and the people that I've talked to in other places. Most centers get a shipment of X, and that's what you have to take.
Okay. We have many other questions. Is there a test to see if you were infected before the quarantine date of March 2020? Is there a test to see if you were infected?
I'm not aware of one that goes back that far. I mean, I suppose technically you could have a test that shows, but that's not going to tell you when you were infected. So I'm not aware of one.
Okay. Were any of the vaccines created by or do they use aborted fetuses?
So the controversy with that came up with the, I believe the Johnson & Johnson. And because, the Catholic Church came out and said that, that it was discouraged. And let me see, how did that shake out? The way that it shook out for me was that if you technically, sorta, yes, but it's way, I mean, it's to the extent that the answer should probably be no. But I was querying my colleagues and said, well, it was like, I mean, technically, yes, there may have been some element of a fetal line and so forth, but I'm not sure how scientists are answering that. I do know that the Catholic Church has gone back on it and said that they feel that it's okay to take it, although I have a cousin who lives in New York where her Catholic Church was passing out flyers last week telling them not to take it.
So what is the difference between the J&J vaccine and the mRNA vaccine?
Well, the J&J, the platform is the adenovirus, and the mechanism of action about how it's taken into the cell is adenovirus as opposed to messenger RNA, which is not any kind of virus, live virus or anything like that. That's the difference.
Okay, do we have any other questions on board? If a person gets one dose of the vaccine, what percentage are they covered if they get one dose of the Mrna or the
Yeah, so from what we can glean, so there was a lot of brouhaha going around initially before the Biden and Harris people came in and really ramped up production and stuff like that, to say, well, let's just give one dose and let that be that until everybody gets vaccinated. Most of us that were scientists that go with the scientists, the studies were done with 2 shots. So I mean, you're 2 weeks after you get your first vaccine, you're about 50% protected.
looks like we have. Go ahead, I'm sorry.
Yeah, you're about 50% protected. But we don't know after that 2 weeks and 4 weeks if you still have that, because the studies weren't done with that. The studies weren't done with if, ands, and buts. And remember what I told you this morning. For me, that was more evidence than anything. This woman got her shot on March the 11th, and she is now in the intensive care unit. Now, was she harboring it before? We don't know. But the bottom line is the vaccine did not prevent hospitalization. And from where she is right now, she may not make it. But again, she was not fully immunized. That data about hospitalizations and deaths comes with 2 doses for Moderna and Pfizer and 1 dose for Johnson & Johnson.
Wow.
You cannot make the pharmaceutical companies go, well, what is, because the studies weren't done with that. And people may give you, answers based on, well, some science, but the studies were not done that way.
Do you think that we'll need to get a booster shot in the following years, like a
Yes.
flu shot?
Yes, I do.
Thank you.
I do.
I got a question.
Yes.
Go ahead.
Okay. Since we don't have the pleasure of knowing which shot we get, once we receive it, is it revealed to us so we'll know if we need to come back for a second?
It's always revealed. You will always know what you're getting. You
Well,
don't know. I mean, when you go to the healthcare center, you might not know when you go to the healthcare center whether you're going to get Pfizer or Moderna or J&J. But once you get there, they'll tell you, because everybody gets a card. You get your little card that has it on there. And if it's Pfizer or Moderna, they give you the date that you're supposed to come back to get your second dose. So it's not like, in the clinical studies where, it's once you get it, then they'll tell you, surprise, you got this. So no, it doesn't work that way.
And then on the second end of that, we as Seventh-day Adventists and the conversation through the worldly communication, is that we're taking the mark of the beast by getting immunized rather than stand strong on our conviction that God will cover us and will not be affected by this virus.
Mhm.
Oh, we have Pastor Hood on the line. Is that a question? I'll let Pastor Hood answer that.
Yeah, that's a question. Yeah.
Pastor Hood.
No, the Adventist church is not discouraging people from taking the shot. We have they've already had a panel of Adventist doctors who had a similar program just like this, who basically they weren't trying to strong arm people into taking it, but they were debunking some myths similar to what our guest has debunked today. But it's not a religious issue, it's a medical issue.
And that's good to hear that and know that. Also, being a 70-plus-year-old individual getting ready to take the vaccination, the comfort zone is that our faith is a center of protection in our mindset. Because if we be negative and not have the immunization, the potential is to become contagious. If we be positive and take the immunization, the data shows that we'll be an even stronger component of not having the virus. So it's an individual state of mindset that faith works miraculously in our emotional component rather than in our physical absence. So with this said, to bring it to a close, we have the opportunity to know that even though the flu shots and some of the other vaccinations are not an indication of this mark of the beast component, but of a worldly global safety net that God gives physicians like the both of you, Dr. Banks, if I said incorrect, and also you, honey, Dr. El-Jamah. Thank you very much for being present with us.
I wanna, can I make another comment? So, you know, one of the things I'm trying to figure out how to say this. You know, we, as I have mentioned today, we as African Americans are disproportionately represented by this virus, represented with respect to this virus because of our the comorbid illnesses that we have. And those things have made us more susceptible to acquiring coronavirus. And what I say to individuals is this: some of the things you can start doing for yourself. What is emerging now is that obesity is probably the #2 risk factor for acquiring or getting COVID-19. And so what I think is that people, you know, if we're talking about vaccines, that's all well and good and so forth, but this is not the only vaccine that's going to be coming down the pipe. This is not the end, and maybe there'll be another one. But I think we need to start working on ourselves from a health standpoint. As Pam said, I don't run as much as I. Age, unfortunately, has caught up with me, but I have 80 medals in my age group. But I think we should start looking within ourselves and helping ourselves and doing those things that will prevent us from becoming diabetic and hypertensive and obese, and do some exercise and all these kinds of things. I mean, I believe that God helps those that help themselves. And so, you know, everybody now is suffering from those COVID extra 20 pounds. And so now the sun is coming out, and whether you want to go to a gym or not, that's your choice, but you can still walk outside, you can stop eating and all these kinds of things, or eat more healthy. So, I mean, I guess that's kind of like my stance when I hear, yes, there's mistrust and distrust of this vaccine. And I cannot say, you know, like I said, we're all going to be messed up in 10 years if something happens with us. But what I want to emphasize is that we as Black people, since it's affecting us, let's start working on our own health and maybe not be that one that the virus is out there searching for. because we started to notice early on that obesity was a major risk factor before this data came out. When we started seeing patients on ventilators and coming in the hospital, it wasn't COPD, it wasn't them smoking, it wasn't anything. It was being overweight, and then hypertensive, and then diabetic. All that other stuff came below. And these are some things that I think we need to work on and really need. I mean, you know, Pam knew me when I had more weight, you know, and I try to do all I can to keep that off. And now that COVID is around, it's like, you know, I don't, you know, I'm vaccinated, but I don't think that I'm 100% of this. If it's not this virus, it's going to be something else. So let's work on our own health is where I want to leave things today. Yes, there's mistrust and distrust, and we can think of all the other kinds of things, but we still need to work on ourselves because we are still disproportionately represented in all those things that I just mentioned with respect to health when it comes to COVID-19.
Amen. Amen, sister. Thank you so much for that. And those are the things that as a group that we're going to be doing. As Adventists, we have a health message, and that includes taking care of our health, exercising, eating healthy. So that's a great place to leave us, and trusting in God. One thing I want to mention about Kizzy. Kizzy has said that she was put on this earth for a purpose by God, and that her purpose was to help develop this vaccine so people would not die. So we could look at it from academic, scientific, medical sphere, but we can also look at it from a spiritual sphere also. So I want to thank you. Does anyone have any more questions? Pastor Hood, anyone else have anything they'd like to say? I really appreciate you being here, Doctor.
Thank you. It's been
Yeah.
a pleasure and an honor. It's been great to see you too.
Yes, you
We go
too.
Yeah.
back a long way.
Yes, we do. Yes, we do. We're still here kicking high.
We
That's
are.
good.
Praise God. I do have one question. You
Yeah.
mentioned about obesity, and I've been hearing and seeing about bone broth being a good part of your diet to help combat obesity. So I wanted to know if you had any info or input about this bone broth.
I do
there's-
not.
Okay. Yeah, they say the bone broth helps you to lose weight because you're getting your nutrients, so you're not hungry, and you can continue. It's better for you for your fasting throughout the day, and then have a meal. Your other, pick a meal like maybe your
Right.
lunch or your food, and then continue to sip bone broth. And I'm like, well, being a vegetarian, I don't know if I want to go to that, but if it's a nutritious an effective way to help lose the weight, it would be worth it.
One of the things, I have a podcast with my girlfriend, Dr. Vicki Doe here. We've been doing it now for about 4 years. And when we talk about diets, we try to use the term lifestyle changes as well, but we just try to say to everybody, whatever lifestyle change you decide to make in terms of weight loss, it needs to be sustainable. It needs to be something that you can stick with, because everything gets boring. Everything gets boring. So whatever you decide to do in terms of whatever your choice is to lose weight, just make sure that it is something that is sustainable so that you won't, get off track. And if you do get off track, it's something that you can get back on and deal with.
Okay. Thank you. Anyone else? Well, we are at the top of the hour. We're going to close. Does anyone else have any questions? So it's an awesome information. Thanks for sharing. Now I won't think the vaccine will turn me into a zombie or a lizard
No, I
person.
mean, everybody's, one of my relatives said, well, Dee, you're going to turn into a zombie. Didn't you see that movie, I, Legend, where they
Right.
turn? I mean, I'm not laughing at these things.
Right.
I address mistrust and distrust. I don't discount anything that this government or anybody else will do. I get it. We are in the middle of a pandemic, y'all. And we have got to do something to stop the spread of this virus, because I'm personally tired of seeing my friends die. Now we have 2 city councilmen here that have just died within the last 3 months. It's getting too close to home.
Yes.
So we are in the middle of a pandemic. I get the mistrust and distrust. I grew up in the South. I get it, but we're in the middle of a pandemic.
Amen. Okay, thank you so much, Doctor.
Thank you, guys. Thank you so
I'm
much.
gonna have
God
a-
bless you all.
I'm gonna have Pastor Hood just give us, Pastor Hood, could you give us a closing prayer, please?
Sure. Thank you so much for doing this. And I hope that you will accept our invitation to follow up. I'm sure this is going to be the big issue for some time to come. So thank you for coming. Dr. El-Jamah, thank you for coming up with the idea. We really appreciate the opportunity to hear and to get our questions out there. So let's just close out. Lord, thank you for keeping us. We know that in all the many ways that you heal, sometimes you do it through a miracle, but many times you do it through the intelligence that you've given us to be able to problem solve and work through things, sometimes even through trial and error. And so, Lord, with all of that, we cast all our cares upon you. We ask, Lord, that you bless our presenter and everyone involved, is our prayer in Jesus' name. Amen.
Amen.
Good night, everyone.
Good night, everybody.
Thank you. Thank you so much.
Thank you.